Right, well, good afternoon. Donald, thank you very much indeed and to the FPM for inviting me to give this talk, and I only hope that I can match the standard of the previous speakers and the previous readers. I suspect there's only one thing worse than writing guidelines, and that's listening to somebody reading them. So let me reassure you that's not what I'm going to do. I'm going to be rather selective, as you will see. But I should probably start by declaring some conflict of interest in that quite a number of the WHO guidelines I'll talk about I was involved in writing. So I thought we would just look a little bit at a comparison between the year that William Osler died and our current year. I'll move on to what guidelines we use, some recent changes in practice as a result of those guidelines, some other new developments which will, I think, become guidelines quite soon, and summarize some of the international guidelines that have made a difference internationally, not so much applicable to the UK, perhaps. So the world in 1919, population only 1.85 billion compared to the 7.7, nearly 7.8 that we have now. World War I had just ended and claimed the life of William Osler's son. The Treaty of Versailles that officially ended the war was signed in 1919, and the influenza pandemic was ongoing. General Dwyer had just committed the Amritsar massacre. Russia was in a mess, and the Third Anglo-Afghan War had started. So some things don't change. Tuberculosis in 1919, there were 2 million deaths globally, which is not so different from today's figure, which I'll come to in a minute. 46,000 of those deaths were in England and Wales, as you can see in the graph up here. And you'll notice that 1919 is right down from the peak during the First World War. TB had generally been falling since at least 1840, when records were kept, and mortality, therefore, from TB. But the First World War was a major blip on that graph. Diagnosis was by sputum smear, a technology then unchanged since the 1880s. We'll come back to that too. And treatment can broadly be divided into the possibly acceptable, like bed rest and sanatoria, if you had the resources to go to them, and the downright nasty, which included things like artificial pneumothorax, pumping air into somebody's pleural cavity, a thoracoplasty, where you crunched the ribs on the affected side and collapsed them down onto the affected lung, or things like plombage, where you took tennis ball-like structures and placed them, shoved them, would be more accurate, into the pleural cavity, again to put pressure on the affected lung, which was thought to be a good idea. But there's no evidence for the effectiveness of any of these, really, except possibly for sanatoria from the public health point of view. And this picture at the bottom here, which looks like something out of The Handmaid's Tale, is in fact a physician at the Brompton Hospital doing an artificial pneumothorax, and nursing shortage clearly wasn't a problem. We move to 2019, and we have the internet and animations that go round and round. And the next slides, few slides that I'll show, are from my colleagues in the World Health Organization, summarizing the 2019 Global TB Control Report, which has been coming out now every year for the last, I think it's 27 years. So it may come as a surprise to some of you, I hope not too many, that in 2018, about 10 million people developed tuberculosis, of which 7 million people were notified and reported to national authorities. And this is up from 6.4 million in 2017 because there have been huge efforts to try and find the missing cases. But still, 3 million were undiagnosed or diagnosed somewhere else and not notified, and they may or may not have received treatment. Now, in actual practice, I think many of these are within the private sectors in large Asian countries like Indonesia and India. But there will still be quite a number who are totally undiagnosed and untreated, most of them living in either in isolated rural areas which still exist, or in urban slums where access to care is difficult if you are poor. If you look carefully at this slide, on the left-hand side, we've got the global situation in the last 20 years in absolute numbers. And on this slide, we've got the same figures represented as incidence in terms of rates per 100,000 people per year. If you look at the thin green line here, this represents the estimate of cases per year. And the fuzzy area around is the confidence intervals for those things. And you'll see that in the incidence curve, it's been falling since about 2000. It continued to go up in the early 2000s in the total number, and that's because the population of the world was increasing. The black line is the notification rate of new and relapse cases, which is how we define it. We can go into relapse later if you want. And the red line is the HIV-affected cases, because for ICD, International Classification of Disease purposes, we have to separate those out. If you look on this side, you'll notice the dotted line, which is the 2020 milestone for the End TB strategy, which is the strategy that the world is now using after the 2014 World Health Assembly. And this milestone is a 20% reduction in incidence since 2015, which is the baseline year for the End TB strategy. So what's important is the gap between here and here, and you can see it's a very big gap. So in other words, we are not notifying anywhere near as many cases as we should, as you saw in a previous slide. If you break these numbers down by different regions of the world, what you'll notice, rather interestingly, is that in Africa, this incidence figure looks as though it might be on track for reaching the 2020 target, or almost on track. And this is largely because TB shot up in the 1990s, 80s and 90s in Africa as a result of HIV. Generally speaking, fourfold increase in TB as a result of HIV. And now it's coming down because HIV is better controlled. So it's a kind of artifact in a way, but it looks as though they might reach the targets. Europe almost certainly will reach the targets because we've got more money and better facilities and so on. Elsewhere, doesn't look so good. The Americas, things are going in the wrong direction for reasons I'm not actually sure. I suspect it's to do with data. Eastern Mediterranean region, which is from Mauritania all the way through to Pakistan, is dominated by Pakistan. Over 500,000 cases a year, and they really haven't got a handle on it. In terms of mortality, 1.5 million people die each year from tuberculosis still. And talking of Pakistan, a colleague of mine went and met him the other day to talk about TB. And his reaction was, TB, I thought we'd solved that problem ages ago. Turned to his Minister of Health, who rather shamefacedly said, well, yes, it is actually a bit of a problem. That 1.5 million include 250,000 people with HIV. HIV is the leading killer of people with TB is the leading killer of people with HIV, and TB is also drug-resistant TB is also one of the major causes of deaths related to antimicrobial resistance, which is another global priority program. Drug-resistant TB remains a huge problem. About 500,000 people fell ill with drug-resistant TB, which the WHO defines as rifampicin resistant, which is the main first-line drug. And only 1 in 3 of those access treatment. That may not be quite as bad as it sounds, because you can't actually get a specimen out of many people. And of those who were treated, only 56% were treated successfully in the 2018 data returns. Preventive therapy, for many years, not a feature of WHO recommendations, although it was used in countries, generally countries that didn't use BCG very much, like the US and the Netherlands. Now it is part of the WHO strategy, and you can see that the figures on preventive treatment are shooting up, but they're still very, very small compared to what's required. I wouldn't urge you to pay too much attention to this map, where the dark colours represent high rates of preventive treatment coverage. And the reason I say that is because they're from Russia and the former Soviet Union, and many of those data you cannot really rely on. For progress in disease, you need money. And the WHO estimates that $10 billion is required, or was required, for diagnosis, treatment, and care in this year, 2019. In order to fund adequately the national plans that pretty well all countries have. But only 6.8 of those billions were available. So that's a funding gap of about a third not funded. Similarly for research, and these gaps have been, generally speaking, there throughout the last 2 decades since we've been collecting these figures. By way of comparison, HIV/AIDS has about 10 times the expenditure on both treatment and research. Now, whether you think that's a good idea is another issue, but just be aware that TB is the biggest infectious killer. It now kills more people each year than HIV. Back in 2018, in September, there was, for the first time, there was a UN high-level meeting on tuberculosis, attended by about 30 heads of state. And you probably can't see it very easily, but I'll just emphasize these ones at the top. They committed themselves to successfully treating 40 million people with TB in the 5 years from 2018 to 2022, which might just about be achievable, including 3.5 million kids and 1.5 million people with drug-resistant TB. They also committed themselves to the much more difficult target, I think, of treating 30 million people with preventive treatment to prevent latent infection developing disease. And they committed to raising significantly more money than they do at the moment. The other major commitments relate really to sort of political, administrative, and UN speak things, so I'll ignore those. All right, let's move on to guidelines. So, what guidelines do we have? Well, in the UK, there's NICE. And if I want to do one thing in this talk, I think it is to suggest to you that NICE is good, at least when it comes to TB, and to encourage you to love your guidelines. And one of the things that distinguishes the NICE guidelines from other guidelines is that they take into account cost and cost effectiveness, which I think is, personally, I think is important, whereas many of the other guidelines focus rather more on the clinical and, to some extent, the public health, and not so much on the costs. In the US, North America, and also used widely in West and Central Europe, are the American Thoracic Society, We Help the World Breathe, guidelines, into which Centers for Disease Control take part, and the Infectious Disease Society of America. They're described as being endorsed by the European Respiratory Society, and I don't really know why that is, because when you look at the authorship, there are Europeans in that list. So that's really why they're used in Europe, I think. For the rest of the world, the developing world particularly, the World Health Organization is looked to as the major source of advice and guidance on tuberculosis control, with some exceptions, particularly China. China's developing its own approach, and to some extent India now, although India is still paying a lot of attention to the World Health Organization. Right, now, to understand what follows, I need to give you a quick summary of management of TB. So if you think you already know this, you can chat quietly amongst yourselves. For those of you who don't, what I've done is I've used the NICE structure, more or less, just to point out that TB management is carried out in the context of trying to make sure that all the people who are going to do the work know about the disease, are aware of it, and are adequately and appropriately trained to do the work they're supposed to do. This includes not just doctors and nurses, but also paramedics, social services, voluntary staff, and so on, who in this country are likely to be working with high-risk groups. Latent TB usually arises as a result of contact tracing in households. And this is detected with a MON2 test, where you stick a needle just into the top of the skin with a purified protein derivative and see if you get a reaction, or the interferon gamma release assay. Generally speaking, NICE seems to favor the MON2 test. ATS, and so on, the IGRA. And then you can treat with several possible regimens ranging from 6 months of isoniazid through to 12 doses of weekly isoniazid and rifapentine. Active drug-susceptible TB is usually diagnosed as a result of screening with a chest X-ray and symptoms, of course. 3 sputum samples are requested, although WHO now recommends 2 if you have good quality control on your laboratory. Microscopy and culture are carried out, but usually those are a bit slow, so increasingly we're using nucleic acid amplification tests, or even whole genome sequencing in this country. Treatment has been for 4 or 5 decades now, a 6-month course of treatment. And that 6-month barrier has proved very difficult to get underneath, and I'll touch on that in a moment. The accepted notation for this is E for ethambutol, H for isoniazid, R for rifampicin, Z for pyrazinamide for 2 months, followed by 4 months of isoniazid and rifampicin alone. Drug-resistant TB is diagnosed in much the same way, but line probe assays are used to detect the genetic signatures for resistance, and whole genome sequencing too, of course. Treatment is with at least 4 effective drugs, and I'll say more about that in a moment. For follow-up, which is crucial in TB because the treatment lasts 6 months or much longer if it's drug-resistant, then you need a patient care plan, which usually revolves around directly observed treatment and quite a few other things. And it's, do you give DOT for the initial phase only, or do you do it for the whole course, and how do you do it, and where do you do it? Monitoring and evaluation, absolutely crucial for monitoring the performance of your TB control efforts. So you must notify and you must report outcomes, and a pile of other stuff as well. And all this is done in the context of organization and management. Now in this country, we have TB control boards. Sounds a bit old-fashioned, but they were put back in, I think, in the 2016 guidelines. And in other countries, you've got national TB programs that organize all this. Right, so what does NICE say at the moment? It covers clinical guidance and public health approaches. It mandates, typo, PHE England, Public Health England, and the NHS to establish TB control boards, largely through multidisciplinary TB teams. And NICE recommends, which is interesting to me, a cohort review, at least quarterly. And I wonder if we used cohort review for some other groups of patients, like, for example, those with heart failure, whether you would be able to see increased rates of take-up of effective treatments. The most recent revisions, well, September of this year, to avoid fluoroquinolones because of the extremely rare serious musculoskeletal side effects. Well, actually, the only indications for fluoroquinolones in TB are for life-threatening multi-drug or extensively drug-resistant TB. So I suspect that might override the extremely rare possibility of side effects. In June of this year, the definition of contacts was extended, particularly in schools, to include teaching assistants and people outside the classroom that affected people might come into contact with. 2 things about the 2016 version. The age of contacts for whom to consider treatment of latent TB was raised to 65. It was actually raised from 35. And I've spent nearly 40 years in TB control, and that was a hell of an increase. It turns out it's not as a result of new evidence, it's a result of reconsidering old evidence, which we can discuss if you like, if there's time for questions. They also said, don't screen contacts of non-pulmonary TB. And this attracted widespread criticism at the time. New evidence has just come out. So this year, this paper was published here showing that looking at contacts of non-pulmonary TB costs you about £78,000 to achieve a quality-adjusted life year additional. But it only costs only £30,000 if you're looking at contacts of pulmonary cases. So on that basis of that comparison, they decided it wasn't worth doing. that can be discussed because you find less TB in the non-pulmonary than you do in migrants when you have to look at those. So looking at the ATS CDC IDSA guidelines, they split them into guidelines for drug susceptible and drug resistant. And what's interesting in the 2016 drug susceptible guidelines is that they now recommend a 4-month treatment regimen for smear and culture negative TB, provided that various standards are met, particularly standards related to the quality of the microbiology. And I think this is although this has been recommended in research papers off and on since the British Medical Research Council were doing their studies, I think it's the first time the guidelines have come up with an under 6-month treatment. Just a word of warning, the abstract, I got that wrong in the abstract. It's not 4 months treatment for those with low smears or non-cavitary disease. That's what came out of this paper here, published this year. But actually, the ATS decided to be very cautious and restrict it just to the smear and culture negative group. Now, multi-drug resistant TB. My respiratory registrar son-in-law looked at this slide yesterday and said, look, this is a bad slide. It's got too much on it. You can summarize it very quickly. And you can say that, yes, MDR-TB is defined as resistance to isoniazid and rifampicin. And WHO started off with a lot of toxic shit. And you finish up with a 1-year regimen, which is much less toxic and avoids injections. So that's the short version. Some of you might, especially perhaps the poets, might be interested in these old-fashioned drugs, cycloserine, ethionamide, prothionamide, which have a nice ring to them. But actually, these are highly toxic drugs, which we only used for treatment of drug-resistant disease because they were there on the shelf. They had been developed in the 50s and 60s. They weren't being used for anything else, so people weren't resistant to them. But they were on the shelf because they were toxic. Anyway, we started using them to begin with in various kinds of regimes, mixing them with fluoroquinolones where you can. Patients really couldn't work while they were taking these regimens. They required serious family and financial support to manage the treatment. And treatment success worldwide was less than 50% back in 2014. The regimen was cut to 12 months, but with rather more drugs as a result of work, interestingly, in Bangladesh. Treatment success is now up to 56%. But now we're into the all-oral regimen. So if we go to the ATS guidelines, just a quick word to say that these are much more based on evidence now, involving the grade recommendations and PICO questions. But interestingly, the first 6 things that the ATS recommends are not backed by any evidence, largely because, well, if you look at them, they can't really be put into a controlled trial. So you have to start off by having your TB, MDR-TB treatment undertaken by a recognized expert. They recommend rapid identification through molecular tests so that you get on with it because it's a life-threatening condition. Treated only with drugs that have been proven to work against the isolate the patient has. You monitor in as many ways as you can. You center the patient's care on their beliefs, their culture, their social circumstances. You don't, as many countries still do, rock up to the patient's home in a program Land Cruiser and a pile of people fall out and go and talk to the patient. And stringent adverse effect monitoring, which does mean training the patient to recognize the nasty side effects of some of these drugs. So they recommend 5 drugs in the initial phase, 4 drugs in the continuation phase, with an initial phase of 5 to 7 months after culture conversion, which may take some months, and a total duration of 15 to 21 months after culture conversion. So they're being rather more stringent than WHO at the moment. They're choosing drugs from the table, starting at the top. So you start nowadays, in the last few months, with bedaquiline, a new drug, which I'll come to in a moment. You add a fluoroquinolone, one of the later versions, Moxi or Levo. You try and add linezolid and maybe clofazimine, which is a repurposed leprosy drug. And then the bacteriostatics down here, cycloserine, ethambutol if it's still sensitive, and pyrazinamide. Injectables, generally, people try and avoid. Delaminid, which is a new drug you may have heard of, there isn't enough data to say what we should do with delaminid yet. And down here are some of the old drugs which people are still using when there is either resistance here or patients are sensitive to those drugs. They have hypersensitivity reactions to those drugs. Bedaquiline is the first anti-TB drug to have been registered in both the FDA and the EMEA in the last 40-something years, or for 40 years. Now we have not only bedaquiline, but delaminid and pretominid. And interestingly, while those guidelines were in press, the FDA approved in August a novel regimen for extensive drug-resistant disease, XDR-TB, and some MDR-TB, under their limited population pathway for antibacterial and antifungal drugs, which is basically a way of encouraging drug companies to do research in basically areas where they're not going to get much commercial return. And they've approved a 6-month all-oral regimen known as the BPAL regimen, which is bedaquiline, which we've already touched on. And bedaquiline is a diaryl quinolone, the research work of which came out of the TB genome sequencing done about 30 years ago. And pretominid, which is a nitronidazole, and has been around for a long time, being bought by successive drug companies until it finished up in a public-private partnership supported by the Rockefeller and Bill Gates. And they have finally developed it into this regimen. And linezolid, which many of you will know, is an oxazolidinone. Much of the data came from the NIX-TB trial in South Africa, which had phenomenally successful results, first presented in the Union Against TB and Lung Disease conference a couple of years ago in The Hague. 1 year ago in The Hague. But it was an uncontrolled study, interestingly. However, there were another 19 trials included in the data. So the way is now open to using the same drug regimen for disease that we currently classify as drug sensitive and drug resistance, which will make life a whole lot simpler for TB control programs. And this is from last month, a few weeks ago, the Lancet Respiratory Medicine, a phase 2b study done by Connor Tweed here in London, of BPA-Z, which is bedaquiline, pretominid, and pyrazinamide for drug-susceptible patients, and adding moxifloxacin for rifampicin-resistant patients. That's 4 drugs in the rifampicin-resistant group. We use 4 drugs now, so we could think of using this across the board, maybe, when people have had a chance to use it more widely with a phase 3 study and looking at the costs, of course. Right, so these are major WHO guidelines that have come out over the years. So a number of us, a whole team, were involved in developing the DOT strategy, which you may have heard of, Directly Observed Treatment Short Course, which was really the strategy change based on Carol Stiebelow's work at the Union, and really was the step change that kick-started or restarted national TB control programs in the developing world to get on top of TB, and ultimately, about 10 years later, led to the beginning of the decrease in TB incidence. TB control in prisons. Prisons are a huge amplification center for TB, together with HIV and drug-resistant TB transmission. And these were the first guidelines that we prepared for TB control in prisons with the ICRC, International Committee of the Red Cross. Public-private mix, really important when you're trying to integrate these massive private sectors in countries like India, Pakistan, Indonesia, into public sector-based national TB control programs. So that's what that was all about. HIV was causing a huge problem for the management of TB in Africa. So we came out with guidelines in 2004 for collaborative TB activities, and there were another 9 or 10 guidelines on different aspects of that, on surveillance, on adverse effect management, and so on, that came out of that TB HIV work. The drug resistance issues were addressed in the 2006 guideline. We had to pulp that because of the outbreak of XDR-TB that was published in the Lancet from Tugela in KwaZulu-Natal, some of you may recall. And we had to incorporate XDR-TB in the next guidelines that came out about 18 months later. About 15 years ago, we noticed that, or more like 20 years ago, that whilst epidemiological studies suggested that children, that is under the age of 15, should constitute between 10 and even 20% of the number of TB cases in many developing countries, depending on the population, depending on the demographics. In reality, most of these countries were only notifying 1, 2, 3, 4, 5% as children. So there's been a huge drive to try and diagnose and treat more children. And that was all begun with these guidelines here. And then in 2011 was the first set of recommendations to change the sputum microscopy test based on 1880s technology still in use in pretty much all African countries and, well, all developing countries at the time. So this is it's a nucleic acid amplification test that uses a cartridge. It's very simple. You inject the cartridge, put it into a machine, attach it to a computer, and you have an answer in 90 minutes. It not only detects TB, but it also tells you whether there is rifampicin resistance. So that's a major game changer. More recent guidelines, infection control, a roadmap for TB in children, and WHO is at last consolidating its guidelines on drug-resistant TB, and for the niche expert LAM for diagnosing TB amongst the HIV infected. So, in conclusion, for the first time for a long time, there are major changes to the techniques that we're applying to TB control. Nothing used to change. Now we're getting new drugs and new diagnostics. I think guidelines really are important. They're needed, they're useful, they're helpful, and they're increasingly evidence-driven. We're moving away from expert opinion and consensus guidelines, and they really do guide decision-making in the field. So I think we should all use them. But there are outstanding problems. We need to consolidate multiple guidelines, and this is a message, I think, particularly for WHO. And we need to try and disseminate them better and ensure that frontline clinical workers are actually aware of the guidelines. So if you have been, thank you for listening.